today to talk to you guys a little bit about the basic setup for some of the standard OB cases that you'll encounter. This first one will be a C-section setup. Here's your basic setup. We've got your Bicitra, Zofran if you need it, Reglan. This is going to be injected into your bag of fluid. Over here, so Reglan. We have 2 grams of ANSEF. Here's our phenylephrine reconstituted into a bag. So you take the 10 milligram, put it into 100, and that gives you a 0.1 milligram per cc or 100 mic per that you can draw out in your syringe. Here's your 0.75 of Marcaine or bupivacaine. And then take out 2 cc or 100 mic syringe of fentanyl. Okay. So the first thing we're going to start with is cleaning the back. So this solution you want to open over, it's the povidone solution that we use at this institution is actually neurotoxic if it finds its way into the neuraxial space. So you want to open it always away from your sterile field. And then you can grab your tray, pour it again away from the sterile field. Alright, and then at this time I usually say, so okay, a little bit of cold scratchy solution here. And remember to go in circular motion from inside out radius. Toss it into the trash when you're done. Second one, take a nice amount of solution. All right, another cold scratchy here on your back. Again, and one more cold scratchy solution. The towel, same thing with this drape. Protect anything that's sterile. Dab, dab, dab with the back of your hands and discard. Do it. The drape, again, is another thing that everyone opens a little bit differently. This is how I open it. I do partial like this. Gently allow it to unfurl. The bottom part's always going to stick. And then you just tell our little cold plastic drape here, and then carefully place it. Trying to make sure that everything remains sterile. So the best position for epidural, spinal, any of these neuraxial procedures are going to be one in which the parturient's shoulders are nice and relaxed down. Many times your nurse will be standing in front helping bring those shoulders down. We can tell them to tuck their chin into their chest and kind of roll their back down. And many times we'll tell them it's kind of like an angry cat, and to try to focus on putting the lower part of their back out towards us. And to imagine trying to open up the bones in their back is sometimes what I'll tell them. But just as Dr. Turner's exemplifying, just a nice rounded back here. We're fortunate that Dr. Turner has exquisite anatomy and you can see her inner spaces without having to palpate anything at all. But for most of your parturients, they will not be this fortunate. So typically, for most of us, how we like to find the correct anatomical space is to start with palpating the top of her iliac crest. You can actually visually see it. So there's L4, L5, L3, L4 right there. Okay, so already that gives you kind of where on a vertical positioning about where you should be. L2-3, L3-4, L4-5 are all appropriate, but again, you're at risk the higher you go of encountering the spinal cord. So usually L3, L4, L4, L5 are going to be your safe spaces. Okay, again. So if this mannequin is Dr. Turner, if we found our space, the first thing that we're going to do is numb the area. So you can see, so some people like to start from here and superficially kind of inject. I'm not sure if you can see it on the mannequin or not. Some people like to go directly perpendicular, and when you're just right at the surface of the skin, you can inject and create a little local wheal. So once you've created a really good superficial skin wheal, don't be afraid to give them a nice amount of lidocaine, inject all the way into the interspinous ligament, because anywhere that your needle path is going to travel, they're going to feel that. So skin obviously is the first layer. The next layer is going to be the subcutaneous tissue. The layer after that is going to be your supraspinous ligament. So that is going to be the first kind of tough ligament that you'll encounter. And then you'll go through interspinous ligament. Interspinous ligament feels many times very bristly or like bristle. Many times you can hear it crackle. It should feel nice. For many women, it'll feel nice and tight. It'll be the first time that you'll encounter a decent amount of resistance. Okay. After the interspinous, then you'll hit the ligamentum flavum, and that's typically what we describe as the pop sensation. And then after the ligamentum flavum, you're in the epidural space. After the epidural space, there's the the durameter that you'll encounter before you encounter the subarachnoid space for the spinal injection. Those are the layers. And then I grab my 2E needle. The 2E needle, like I mentioned, is 9 centimeters in length. Like I said, each one of these is a centimeter, so be aware as you're introducing your 2E needle, kind of be cautious and wary of your depth if you so. So again, once she is properly numb, at this point I'll tell mom, okay, I'm going to insert the next needle. You should just feel pressure in the middle of your back. If it feels like more than pressure, if you feel a sharp pain or a stinging or a burning sensation, let me know, and let me know if it's left-sided or right-sided. I'll say, okay, pressure kind of in the middle, pressure in the middle of your back. Now, as I mentioned, each one of these is a centimeter. For most proturients, you can insert probably a good 2 or 3 centimeters, and you should be nice and seated. The goal is to be seated into the interspinous ligament. So that's going to be that kind of gristly ligament that you'll feel that's kind of tough. You should be able to let go of the needle and feel like it's securely in place. That is, if it's loose or floppy, you're probably in subcutaneous or you're off midline. So once you feel like your 2E needle is seated into that interspinous ligament, you remove the stylet. At this point, you would utilize whatever loss of resistance technique you have, whether it's air or saline with the glass plunger. And you would then attach it to the 2E needle. Once it's securely attached, you start testing to find what your baseline level of resistance will be. This is going to be this is very difficult to teach. It's a very unique tactile sensation that you'll just get better and better at delineating over time. So it's going to be very difficult for me to describe it, but basically it should not easily give. If it's easily giving, you may be in sub-Q or off midline. It should feel like a nice fluid resistance. Now, you don't want to use too much force because otherwise, you're going to forcibly entrain air into spaces where it shouldn't be. But it should have like a nice little bounce. You'll hear people kind of talk about this little bounce sensation. So the next thing you're going to do is carefully, with consistent pressure, you're going to continue advancing your 2E needle while placing constant pressure in your plunger. Okay, there, we'll begin. So nice constant pressure with your 2E needle, so you can see that I'm advancing while I carefully am plunging down. And then you're going to hit a point where that plunger is just going to give. And that's going to be your loss of resistance. Okay? That's your epidural space. So you'll remove your plunger, and then you'll pick up your spinal. So for the combined spinal epidural, remember, we've hit the epidural space. Now we're going to do a spinal dose with the spinal needle. Okay? So with the spinal needle now, I personally always keep one hand on the patient, one hand on the 2E needle while I'm advancing my spinal needle. So you're going to advance your spinal needle, and you're likely going to feel 2 pops, 1 to 2 pops. They're very distinctive pops, and the biggest piece of advice I can give is if anything feels like you're not sure if that was the correct pop, it doesn't hurt to just take out the stylet and check. So you'll very carefully, very slowly, while keeping your 2E needle in the same place, gently advance your spinal needle until you feel a distinct pop. Once you feel a distinct pop, I then I maintain pressure with my spinal needle and my 2E needle right kind of between my thumb and forefinger. I don't know if that's kind of hard to see, while also keeping a finger next to the patient. Again, I know it looks kind of complicated, but it's just a tactile sensation that you'll develop over time. And then I gently and carefully take out the stylet and observe for CSF. While keeping all of your components in perfect position, because the spinal space can be kind of finicky, and if you make any sudden movements at this part, you could unfortunately undo all the hard work that you did. So keep everything very, very still. Right before the CSF drips out, then you carefully place your spinal syringe on. Well, I personally like to withdraw first before I inject. With the hyperbaric solution, the 0.75% bupivacaine, you should see a swirl of the CSF. Which is just a nice visual indicator that you're in the correct spot. And then you carefully inject your spinal solution while vocalizing injection so that everyone in the room knows that you have injected your spinal dose. And then in one smooth, some people like to at the end also withdraw just to make sure that they have good flow of CSF at the beginning and the end. So you're free to do that. And then you smoothly take out the whole component of our spinal needle while keeping our 2E in place. At this point, we're going to place the epidural. Now recall, so here's our catheter, our epidural catheter. And so quickly, the epidural catheter, oops, the numbering on the epidural catheter, the dashes are in increments of 5. So the first one that you'll notice on this double dash, 5 times 2 is 10. The next one that we get to is this thick line, and that's 12. So 10, 11, 12, 13, 14, and then 5 times 3 is 15, 16, 17, I don't know, 18, 19 is not there, and then 20. So, like I said, the TUI needle is 9 centimeters, so 1 centimeter increments. What I typically do is I take the very edge here, I call that 9, 8, 7, 6. So you can see here I got loss at 5, okay? At 5 centimeters. So typically, again, there's a range. You typically want to thread your epidural anywhere from 4 to 6 centimeters to make sure that you, beyond that, to make sure that you are within the epidural space. The general rule, I think most people say 5 centimeters. So take whatever your loss was, and in this case is 5 centimeters, add 5, so that'll be 10. That's where we're going to leave our epidural, okay? So you're going to go ahead and thread the catheter. You like to take this little plastic tip and secure it right there. You're going to gently thread your epidural. So you're going to thread it all the way. So remember, 5 times 4 is 20. So we're at the 20 centimeter mark. You usually thread it just past that 20 centimeters. So then that way you know you aren't going to pull out the TUI and then lose your epidural. So once you've passed that, then you're going to advance the catheter while simultaneously withdrawing the TUI needle. Okay, so you want to make sure that you're not just withdrawing the TUI needle and then your catheter comes out. So slowly advance, at the same time withdraw. So advance and withdraw at the same time, and advance and withdraw. And then right when I see the tip, I usually just secure the catheter, hold it here at the back to make sure that you don't pull it out further. And then once it feels secure, then you can kind of just gather the slack. Okay, and then this is where we're going to pull out the catheter to the correct spot. So remember, our loss was at 5, add 5 to that, so we're going to go to 10. Okay, so this is 20. We should see 15 coming up right here, so 5 times 3, 15. 13, and then this big thick line is 12. 11, and so the next one should be 10. So I'm just gonna leave right there at 10. The next thing we do is we tape our alligator to the end, or thread it, and then make sure that you have the catheter all the way to the back, nice and secured. If it's not locked in there correctly, you may have difficulty administering medications or withdrawing correctly. Once it's completely to the end and locked in, you want to clamp this down till it clicks, till it's nice and secure. The next thing we'll do is, we would take off the drape, and then once the drape is off, then we will secure our tegaderm and our catheter. Some people like to put a little loop in before you secure it. That just kind of helps keep it in place in case they should move around any. And then you get your little loop, put your tegaderm on there, and then we usually put it over, you'll see we'll put it over the shoulder of the parturient. And I always forget to do this, but right before we lay her down, she's gonna have that fetal monitor, and you just make sure that you put the band back up to secure it, lay mom down. And then that's it. Again, I like to set up in the order that I'm using my equipment. I usually take the gauze out of that tray first, and you know that your prep's gonna come first. And then you'll dab the excess liquid, and then you'll don the plastic drape. So I like to put them over here in the order in which I'm going to use them. Okay, so the spinal kit, if you'll notice, one of the main differences between the spinal kit and obviously the combined spinal epidural kit is obviously there's no epidural catheter. And then you have your introducer needle. And that will be the second step in the process after you've numbed them. And then you'll take your spinal needle. You'll notice it's very small, very thin. That's why you need the introducer needle, because this alone cannot penetrate all of the layers that you need to penetrate. Okay, and then they have a syringe for the actual spinal dose. Okay, so starting from the top, personally I grab this 3cc syringe for our topical. You're gonna use your filter needle to draw up your lidocaine. Here's your 1% lidocaine. Again, open the lidocaine away from the field to avoid any glass shards. And then go ahead and, I usually just fill it all the way. Anytime you're going to put down a sharp go ahead and put it in the sharps. And then I attach the blue needle. It's going to be for your lidocaine. It's usually a 25 gauge. And I like to loosen the tip so that it's easily retrievable when it's time. And then you can go ahead, obviously, and label these if you'd like to, especially in the beginning if you're afraid of mixing up your medications. And then we'll drop our spinal dose in the glass syringe. Again, for the spinal, this is typically 0.75%. The spinal dose is variable depending on the procedure and the attending. It can be anywhere from 1.2 to 1.6. You would draw up whatever amount of bupivacaine is required for this procedure. And then almost always 20 mics of fentanyl is what you would draw up. So first thing that we do, obviously once the patient is in the proper position, we open our povidone iodine solution. And again, we pour it away from the sterile field because it is neurotoxic and we don't want it to potentially contaminate our field. Okay, so I've got some cleaning solution here. It's very cold. Cold solution. I know, I'm sorry. And then again, circular motion from inside out near the area that we're going. All right, second cold solution, cold scratchy. It is for you. And one more cold scratchy solution here. Cold scratchy. All right, very good. All right, use this drape again, just like the C-section video. You want to make sure that you're not contaminating yourself or your field, and so I lightly dab it with the back of my hand. Like this, making sure to try to get in the middle so you don't have any more remainder than you need to. All right, then we're going to place our plastic drape. All right, we've got a cold plastic drape on your back. Make sure good contact. So usually I tell the patient, okay, now I want you to assume that nice position, relax your shoulders down, push your lower back out towards me, very good. And so in this patient, I would proceed to inject my local right here. Move over to our standardized patient, Dr. Butts over here for the remainder of the procedure. All right, this first medication is numbing medicine called lidocaine to help numb your back, but it does sting quite a bit. I'll tell you before I go. Ready? 1, 2, 3. And then remember, make a really good skin wheel. Obviously, you're not going to be able to see it on this mannequin. Penetrate deeper and inject your local solution in all of the areas that you may be going. And so you can use, again, as we mentioned in the C-section video, you can use this numbing needle also as a finder needle. So you can kind of redirect up, down. If you feel a spinous process, you can remember that and remember to maybe have to go slightly superior to that location, or if you're running into lamina, you can figure out if you're off midline or not. So using it both for numbing and to help direct your needle course. The next step in this process is going to be using the introducer needle. We take our introducer needle and gently place it midline. And for most patients, you can hug this needle. And then we pick up our spinal needle, bevel up with our indentation up over here. And very carefully hold the introducer needle and hold your spinal needle very gently and carefully. Advance. And on the spinal needle, you should feel 2 pops. The first one is that ligamentum flavum before the epidural space, and then the duramator, it's that the tough mother. And then, there we go, pop, pop. Before we take out the stylet, you want to carefully hold both of the introducer and the spinal needle in place while you remove your stylet and check for CSF. But if you are in the correct space, you'll slowly see CSF start to return out of your spinal needle. Once you see CSF and it just before it starts to drip down, you carefully grab your spinal injection and very carefully, again, without moving these, because again, any millimeter advancement or withdrawal can potentially lose the space, carefully attach the needle. Some people like to carefully withdraw. You can see a swirl here, and then you would inject your solution. And then at the end, some people also like to confirm with a swirl at the end. Once the spinal injection is completely in, you grab all of your components and in one fell swoop, withdraw everything. All right, and then at that time, you would set the patient down and attach your EKG leads, turn your blood pressure cuff to 1 minute cycling, and monitor for hypotension. I also just want to briefly touch on the signs and symptoms of a high spinal, since that is one of the more serious consequences of a spinal injection. So once you lay your patient down, again, cycle your blood pressure cuff in 1 minute cycling. Sometimes tachycardia shows up before the hypotension, so be aware of that and be alert for a brisk tachycardia, which may indicate that the hypotension is soon to follow. Profound hypotension occurs because of basically a sympathectomy, so you're hitting those cardiac accelerators from when it's higher than T1 to T4. Or your patient may complain also of a subjective shortness of breath, feeling like they can't breathe. If a spinal is starting to get too high, one of the things that you can check is hand grip to see if it's starting to affect T1, C7, starting to look at your cervical nerves as well. And then obviously any signs of CNS or cardiovascular disruption beyond that would be signs of, basically impending cardiovascular or respiratory collapse. So the patients will complain of they feel like they can't breathe, they may not be able to squeeze your hands, they may have numbness and tingling of the lips, things like that. If it was truly a high spinal to the point where you're afraid of respiratory collapse, your next step would be intubation and symptomatic support. So hope you guys found that these tutorials to be informative and helpful on your first day. Obviously, there's a lot of things that we didn't discuss that you will pick up over the course of the rotation. Obviously, the faculty members are always happy to help and reach out to them if you have any questions at all. And keep in mind that there's a bunch of different ways to do these procedures, but I hope this at least gives you a starting off point. So enjoy this rotation, guys.